Alright, Eric Christensen back again here. Just covered loop diuretics in the last video, and we're going to look over some thiazide diuretics this time. Mechanism of action, there it is. Examples, chlorothiazide, hydrochlorothiazide. By far, hydrochlorothiazide is used most common. You will see some chlorthalidone, metolazone, and dapamide. The only difference between thiazide-like and thiazide diuretics is just really a classification as far as the structure. So in my mind, it doesn't mean a whole lot clinically. There are some clinical quirks and differences amongst these medications. Most of note, you probably see metolazone or indapamide most in CHF or edema. And you know, it's pretty controversial and kind of gets into the weeds as far as, you know, why they might be better or worse. But by and large, clinically and in practice, metolazone is probably the drug you're going to see most for edema or a CHF type situation. Hydrochlorothiazide you will most often see for hypertension. It's in a ton of combination products. And, you know, can be a little bit sneaky that way, where sometimes a lot of patients, maybe even providers, they just see that first drug name and they don't see the dash HCTZ or the dash hydrochlorothiazide at the end. They only see the first name, like losartan, which is a ARB. So yeah, that's something sneaky to look out for that patients definitely miss, and sometimes healthcare providers miss that too. Adverse effects, really going to have a very similar side effect profile. They're going to be used for blood pressure. They can lower blood pressure too much, you know, in some cases. So that's something we're going to need to look out for. Frequency, again, is going to be a major problem with the thiazide diuretics. So again, like I'd mentioned, that elderly case, where we're getting up to go to the bathroom, you know, 5-10 times at night or whatever, making sure these drugs are scheduled primarily in the morning, especially if we have problems like that. Hyperglycemia, so in our diabetic patients, it might be something to look out for. It's something I look out for, but you know, you usually don't see a ton of impact on blood sugars, and it's probably not going to prevent us from using thiazide diuretics. So just something to think about. You know, if you see somebody's blood sugars go way up and you can't attribute it to anything else, if that timing's right in when the thiazide was added, you know, it might make some sense to look into that. You know, if there's any way we can get around it, use a different drug. Whatever the case may be, but again, I wouldn't worry about it too much in most cases. Electrolyte imbalance, hyperuricemia. If you remember, uric acid, important in gout. So if you see a thiazide diuretic added, and then shortly thereafter you see a gout flare, you see an addition of allopurinol to treat hyperuricemia, we better be looking at that and making sure that that thiazide diuretic isn't, you know, maybe we can switch to a different diuretic to try to avoid that polypharmacy chain and the addition of other meds to treat a potential side effect from the thiazide. Another unique one, the hypercalcemia is a little bit unique from the loop diuretics, in that loop diuretics actually get rid of calcium, but the way these drugs work, you're actually going to increase calcium. So that's one little quirk that's definitely different from the loop diuretics. Hypokalemia, hyponatremia, so again, sodium, potassium, thiazides are going to deplete those. So it's really important that we monitor those for electrolyte imbalances. There's a quick overview of the thiazide diuretics. More questions, you know, feel free to reach out to me on Facebook, Twitter, and certainly the website as well, meded101.com. Thanks for listening.